this is just sort of a breakdown. The first hour we're going to talk about some pretty dry stuff, some congenital malformations, a little touch on neuromuscular disease. The second hour we're going to talk about infectious complications and asthma, and then we're going to just cover sort of the hodgepodge or the miscellaneous others after that. Somewhere probably around infections is where I'll take just a quick break. All right, so let's get started with the question, see who's awake. It's probably not me. A full-term neonate develops cyanosis and increased work of breathing shortly after birth. The cyanosis is relieved with crying. These episodes appear cyclical. They occur during rest and with feeding, but they resolve with crying. Your differential diagnosis would include laryngomalacia, choanal atresia, piriform aperture stenosis, transient tachypnea of the neonate, or BNC only. So that's about the breakdown that I usually see. The correct answer is B and C, and I'm going to talk about both of those. Okay, so the first one, choanal atresia, seen in about 1 in 7,000 live births, and that vignette is pretty consistent with what you would see on your boards for choanal atresia, and most people get that. If it is bilateral, then the presentation is exactly what we just talked about: upper airway obstruction, noisy breathing, and then that cyanosis that worsens with feeds, worsens with sleep, because as we all know, neonates are obligate nose breathers, and then improves when they open their mouth and they start crying. If it's unilateral, the presentation is going to be a little bit different. This is going to be an infant who presents later on in life with either unilateral nasal discharge, sort of like a foreign body type presentation, or with unilateral nasal obstruction. So for the diagnosis of this, you attempt to pass a 5 or 6 French catheter from the nose to the oropharynx, and then if you cannot, then you do the CT with the nasal contrast to confirm it. For your boards, remember to think about things that go along with that, because that vignette's pretty classic and pretty easy. So they may not ask you, what is this, but rather, what associated anomalies can you see with this? So it may be associated with like Charge or Treacher-Collins. As far as management of this, of course, you've got to establish an airway for these children, and you've got to establish a means for feeding. So an oral airway, gavage feedings, and then consultation with someone who can come in and do a transnasal puncture or stenting, or even resection of that nasal septum with or without stenting. So then the one that usually gets people is this one, the piriform aperture stenosis. And so what this is an overgrowth of the bone at the anterior opening, or the piriform aperture. So they present very similarly to a choanal atresia. So they've got noisy breathing, they go into distress that worsens with feed, improves with crying. And this one also can be seen with other anomalies such as craniosynostosis or pituitary abnormalities. Again, CT will help establish your diagnosis, and what you're going to see is just at that bony opening, you're going to see that it's very, very small. Often nasal stenting is all that you need for this, though. Okay, we mentioned this just a minute ago, but unilateral nasal discharge, they love that one on the boards, particularly foul-smelling unilateral in that toddler age group. You would think about foreign body. And then epistaxis, I'm just sort of going through a couple of other nasal problems so that we can get those out of the way. Remember with epistaxis, most common cause is nose picking. If you've got like an adolescent who presents with epistaxis, of course you're going to think along the lines of the hematologic workup, whatever, but also keep in mind drug abuse in the adolescent population. And then if for some reason your boards mention nasal polyps, think about CF. You know, if they've put it in there, they're putting it there for a reason, and I'm sure everybody has said that for the last week. But if they put it there, it's there for a reason. So think about CF. The other thing you want to think about is allergic rhinitis, chronic sinusitis. Then think about that aspirin triad where you've got nasal polyps, asthma, and aspirin sensitivity. Nasal steroids often are very beneficial in at least reducing the size of the nasal polyp. Okay, so the way I've done the congenital malformations, and I usually say this at the beginning, but I just started at the top of the airway and we're just working down. So as we move down, the lingual ankyloglossia, or tongue-tied, is a restriction of the tongue movement caused by a prominent lingual frenulum. That is such a tongue-tire. The incidence is 3 to 5%, usually male predominance. That's a common theme that we're going to see with most congenital anomalies in the respiratory system, is the male predominance. Most of these infants do well. If they do require frenulectomy, this is an outpatient procedure. And then a lingual thyroid, that's the failure of the thyroid tissue itself to descend from the base of the tongue into the neck during development. So as it enlarges, you can see airway obstruction, and that would certainly be an indication to go in surgically and remove. But usually you can just reduce that remnant with thyroid hormone and just sort of bypass that. Okay, and then thyroglossal duct cyst. This is a midline mass in the neck. It's cystic. For the most part, these are asymptomatic, but if they do become infected, they can rapidly increase in size. Where it's located would cause airway compromise because of extrinsic compression on the airway. Okay, so let's move on to the next question. We have a 4-month-old little girl that's brought in, and mom says she's just making all kinds of crazy breathing sounds. She says it started shortly after she was born. She hears it when the baby breathes in, and you're thinking this is probably laryngomalacia. So regarding this diagnosis, and I know this is bad verbiage, never ask a question and say all but I'm doing it anyway. Regarding this diagnosis, following statements are true except it's the most common congenital anomaly of the larynx and the most frequent cause of stridor in infants. It's made worse with exertion, crying, feeding, agitation, or supine positioning. It typically develops within the first few weeks of life, decreases in severity over several months, and resolves by 6 months of age. The diagnosis is made by flexible laryngoscopy while the patient is awake so that you can see it under dynamic conditions. So which one of those is not true? Interesting. Okay, so the correct answer is C. And we'll talk about that. So remember with your laryngeal lesions that the most common thing that you're going to hear is stridor, and it's usually inspiratory. It can be biphasic if it's really severe, but usually it's inspiratory. They can also present with hoarseness, feeding disorders, etc. If what you hear is an expiratory sound, that sound is coming from below the thoracic inlet. Okay, so that's going to be like a tracheal anomaly or multitude of other things, but it's going to be below the thoracic inlet. So laryngomalacia, it is a common congenital anomaly of the larynx. It's one of the most frequent causes of stridor that the pediatrician is going to hear, probably second to croup, I would think. It's usually self-limiting. So what was wrong with it? The stridor typically develops within the first few weeks of life. It actually gets worse over the next several months, and that's a very key point to be sure and tell the parent that this is actually going to get worse before it gets better, or she's going to think you don't know what you're doing. So really severe cases, they can actually have respiratory distress. They can have feeding difficulties because they're working so hard to overcome that malacia. Again, it's made worse when they get upset for any reason, if they exert themselves, if they're crying, if they're agitated, and then if they lay flat on their back. So one of the nice little tests for this in your office would be to take the infant and flip them over onto their stomach and see if that sound that the child is making actually diminishes. You can also lay them over on their side and extend that neck, and that should decrease that sound. So the other part of the question that was wrong is that it usually resolves somewhere between 18 and 24 months, not by 6 months of age. The last one, however, is correct. They do need to be awake so that you can see this under dynamic conditions, because if you sedate this baby and you're ventilating for them, then you're distending that airway. You're never going to see it. For really bad cases, sometimes we need to place a trach, but usually there's lots of stuff we can do before that. So we can do epiglottoplasty or supraglottoplasty, where you just essentially shave back the part that's flopping over their airway, and that usually will relieve it. And this is just an example showing, how this can completely flop over and close off that airway. Okay. So as we continue to move down the airway, subglottic stenosis would be the next thing that we would see. It can be congenital, it can be acquired, and you're going to be able to differentiate between these two by, number one, a history. Has this child had multiple intubations, multiple instrumentation to that airway? And often when it's acquired, the symptoms are not as severe. There's a narrowing of that cricoid lumen, which is just below the cords. Usually if it's congenital, it's going to improve as they get bigger. The best way, let me say that, the best way to make this diagnosis is to actually look in there and see it. You can do treatment for this. You can do like a laser resection and sort of shave back that area that's become narrowed. But the concern is that it's going to scar back over and be worse than what you started with. And so unless it's really severe and the patient is extremely symptomatic, we typically don't do anything with these. So you can see here that narrowing just beneath the cords, and that's what we're talking about. And if you have access to pulmonary functions with flow volume loop, this is the classic flow volume loop for subglottic stenosis, where you have a blunting of the expiratory limb. It just makes like a big square. And you have a similar blunting of the inspiratory limb, and that's a fixed obstruction. All right. I told y'all this is pretty dry stuff right now, so just bear with me. So the next one would be glottic webs. A web can be partial, so that only part of the area is webbed off, or it can be complete. They can present with stridor, they can present with abnormal cry, or if it's a complete web, then of course they're going to have respiratory distress. I think the big thing about glottic webs is associated anomalies. Remember velocardiofacial syndrome, and to check for 22q11 deletions. So they may show you a web and say, what else should you be looking for? And the answer would be to check for the 22q11 deletion. And this is an example of a partial web. You can see the webbing right here. All webs are just a spectrum of disorders, and they can be glottic, they can be supraglottic, they can be subglottic, but most, 3/4 usually, are involving the glottis. And it's just a failure to recanalize as the embryo is developing. Okay, one really rare anomaly would be tracheogenesis. These infants present in respiratory distress as soon as they're born and die shortly after birth. There are 3 types. The first being that the proximal portion is closed, and then the distal portion communicates with the esophagus. The second type being where the bronchi meet in the midline and there's actually a fistula that goes to the esophagus. And then the third type being where the bronchi communicate with the trachea separately. So you're going to think about this if you have an infant who is immediately in respiratory distress as soon as they're born. You attempt to intubate. You can see where you need to go, but you simply can't pass that tube. And then tracheal stenosis. Usually when we're talking about tracheal stenosis, this is usually segmental. It's not usually the entire trachea. It can occur at anywhere along the trachea, however, and these infants will present with sternal retractions, with shortness of breath, with exertion, stridor. But you also want to think about this in an older child who's presenting with recurrent croup or prolonged croup. Often this one will be associated with like a congenital heart anomaly where you've got compression against the trachea. over a long period of time. And then tracheomalacia. This is an abnormal floppiness of the trachea, just like the larynx, which leads to collapse with expiration. So again, we talked about this before. You're going to hear a stridor, but it's going to be an expiratory sound. Symptoms can be minimal, or the child simply may not be able to overcome that floppiness of the airway. This one, unlike laryngomalacia, is going to present later on, so typically we're going to see this when the infant starts to become more active, or if they develop like an upper respiratory infection, so they've already got an increased work of breathing for some reason. Again, same thing. You've got to have the infant breathing dynamically to be able to see this. If you're ventilating and distending that airway, you're just not going to catch it. There have been some severe cases where we've actually had to trach these children. We've had to resect out parts of the trachea that are floppy. And you can stent, but the problem with stenting is that often these stents grow into the airway, and then you've got a child who's growing, but their trachea is not, because that's where you've got the stent. And obviously stents don't grow. So this is an example of a child who had really bad tracheomalacia, and I'm sitting like at the end of an ET tube, and you can see when he breathes in, it's nice and open. However, when he breathes out, everything just flops closed at the very base of that tube. This particular child also had bronchomalacia, so you can see that demonstrated here as well. Same thing as tracheomalacia, just involving the bronchi. All right, so now we're going to move a little bit further down into the airways proper, talk about congenital lobar emphysema. This is an overinflation of a particular lobe. Can be due to a defect in either the airway itself, or can be due to a defect in the parenchyma with an increased number of alveoli in that particular lobe. Most commonly seen in the left upper lobe, but can be seen in the right middle, right upper, really anywhere. And these infants will present with respiratory distress or with nothing at all. This may be an incidental that you pick it up. Chest x-ray, and I'm going to show you an example. Overinflation, air trapping, mediastinal shift. And you can differentiate this from a tension pneumothorax because there are still vascular markings within this area. Now, they're not wow, but they're still present here. But you see the overinflation. You can see the edge of the lobe here where I've just moved. You've got depression of the diaphragm on the same side. That's a space-occupying lesion, so it's shifting everything down and away. You've got some compression of the normal tissue underneath that, and then the mediastinal shift. So the big thing with this is make sure that you know this is not a tension pneumo, because if you stick a needle in there to aspirate, then you've just stuck a needle in the lung. If they're in really bad distress, then of course resection of that lobe would be what you would do. But as long as the patient's doing fine, then you're just going to watch and manage, and often this will resolve, although there's just not a whole lot of studies out there. But it appears that this is going to resolve on its own with most. Okay, pulmonary hypoplasia. So this is a very common cause of neonatal death, associated with premature rupture of membranes and premature delivery. And prognosis, of course, is going to depend on why you've got pulmonary hypoplasia in the first place. So if you've got this as a result of congenital diaphragmatic problem, then they may do worse. So it just depends on what else is going on with the infant. These children can be managed with ECMO until their lungs get big enough to manage them with mechanical ventilation. Or if they're adequately ventilating that way, then ventilate them until we have adequate lung growth. So this is a young lady who obviously made it beyond infancy, who has pulmonary hypoplasia, but was a very nice x-ray to demonstrate this. You can see that the left lung sort of took over for her, and you've got herniation of that left lung across the midline to compensate for that really small right lung. And then you can see the elevation of her hemidiaphragm on the lateral view. All right. Another really rare thing, I can say I've seen one in all of my training, scimitar syndrome. This is where the pulmonary venous blood from all or part of the right lung is returned to the IVC, either just above or below the diaphragm. So in the pediatric population, this usually has a bad prognosis. It's usually a very large shunt, and these infants present with heart failure, respiratory distress. There is an adult form that has a small shunt, and they usually do much better. Never seen that in adult. And then pulmonary arteriovenous fistula. This is right to left shunting of the blood from the pulmonary veins into the left heart. Systemic blood into the pulmonary veins in the left heart. So these infants will present with shortness of breath. They can present with hemoptysis. They can present with a persistent infiltrate that's just there and not resolving. It can be associated with other anomalies, just like most of these others. Rendu-Osler-Weber syndrome is the most common one that we see associated with this. As a little tidbit, 20% of patients who have HHT will have an AVM, so not all do, but about 20% do. And treatment for this is just ablation, and then if ablation is unsuccessful, then of course surgical removal. And this is an example that shows really nicely the arteriovenous filling as we go through the subsequent cuts. And then you can see here where it's moving right back out of that fistula. All right, sequestration. So a sequestration is very likely to appear on your boards. Many of these really rare ones, if they ask it, I think it's just going to be such an obvious, this is what this is. But sequestration, I think, I would look for this. Sequestration is a mass of abnormal, non-functioning tissue. It's fetal tissue that during the budding and branching as the lungs are developing, this one just sort of broke itself off from that. And is segregated from the main respiratory tree. It has its blood supply coming from systemic arteries and sometimes can arise directly off of the aorta. It is uncommon, but they like questions on this for some reason. There are two major types, an intralobar and an extralobar. The intralobar simply means that it's contained within the visceral pleura of the lung, and this is the most common one. Extralobar means that not only does it have its own blood supply, but it's also got its own visceral covering. So, as I said, it's sequestered, it's embryonic, it's cystic, it doesn't function as normal lung tissue. It often becomes infected, can become bronchiectatic. Typically, we see this in the lower lobe, and then, like I said, its arterial supply may arise directly off the aorta, could be thoracic, could even be abdominal aorta. So I'm going to just talk a little bit about each of those. The intralobar, like I said, it's within the visceral pleura, often in the lower lobes, but you can see it anywhere. The systemic arteries are likely to be very large, and then it's going to drain into the pulmonary system. This one we often see later on, late childhood, early adolescence. The extralobar, however, like I said, it's got its own covering. It's the classic description, and they talk about buzzwords, buzz phrases, what you need to look for. A ball-like mass between the diaphragm and the lower lobe. That's a really good one if that's the description. Communication with even the respiratory tree or the GI tract is rare, but certainly can occur with an extralobar. In this one, the systemic arteries are often small. Its venous drainage is not through the pulmonary system. It's through the systemic circulation and often through the azgus. With the extralobar, most of these cases are diagnosed earlier, usually before 1 or 2 years of age. Again, males more commonly affected. And infection is less common in this type, But again, on the boards, the classic vignette's going to be something like recurrent abscess formation, recurrent pneumonia in the same area, typically left lower lobe, somewhere between the right above the diaphragm, that sort of thing. So chest x-ray may show this triangular shape, density in the lower lobe. CT scan can help, but really an MRA is what's going to give you that answer. And not only give you the answer, but it's going to tell you the blood supply as well, which the surgeon's going to need to know for resection of this. So this is one example of a patient who had a sequestration, not in the lower lobe. Of course, clinical practice never works exactly like the boards, right? And so you can see that there's displacement of vascular markings, but just a ball-like mass that's sitting there. And this one is a little more classic in appearance. You see that on the lateral view there's something that appears to be here in the lower lobe. And then you can see very nicely here the blood supply coming into this triangular shaped density. And just an enhanced view. So bronchoscopy is really not going to be helpful in diagnosing this because I just said it doesn't communicate. And so often, even if there's an abscess formation in that area, I'm not going to see purulence within the respiratory tree. Again, treatment is resection. You need to know what those blood supplies are before you get in there, though, so you don't make a oops. Clinical course without resection would be recurrent or persistent infection, though. Okay, and then bronchogenic cyst. So as everything is budding and branching, we just talked about that. This one sort of pops off and goes its own way as well. And it can go anywhere. It can go in the mediastinum, hilar area. It can even go down to the GI area. And this one is one of the more common that we're going to see. If it enlarges due to infection and extrinsically compresses on an airway, then we can see a child who's in distress. And with that, what we're going to have is cough. We're going to have what kind of stridor? Expiratory stridor, very good. Or wheezing, shortness of breath. Typically, though, if we don't have that episode of infection and rapid expansion and airway compromise, this is something we're going to pick up later in life and maybe even an incidental finding. On chest x-ray, it's going to be round, like a water density mass. It's perfectly well circumscribed. If it's compressing, it may even look like a congenital lobar emphysema like we just talked about because you've got extrinsic compression of that airway, which will then have air trapping behind it. If it's within the mediastinum, a barium swallow might actually show you that posterior displacement of the esophagus, anterior displacement of the trachea. Treatment for this is resection, and the reason for resection of this is because, number one, there is that potential for infection and rapid expansion and airway compromise. Second is it also has malignant potential because it is embryonic tissue. It is not normal functioning. So this is a nice example here. You see on her x-ray she had a very nice, perfectly well circumscribed area that was sitting within the hilar area. And it looked exactly like this. Okay. So now we're going to talk about the chest wall pretty quick-like. So kyphoscoliosis, most of these cases are idiopathic. The remainder that we see, and the ones that I really pick up, are those that are associated with neuromuscular disease or those infants who have rib or vertebral anomalies. With a curvature of 50 degrees, we're going to start to see some restrictive changes on lung function, and then greater than 90 degrees, they have cardiopulmonary compromise. For most children, if they're caught early enough, then bracing will correct this problem. The types of patients that I see usually are the ones that are undergoing surgery because they have neuromuscular weakness or some other vertebral bony anomalies. This is an example of one that was certainly greater than 90 degrees. And you can see the restriction on pulmonary function testing. Restriction is often suggested on spirometry when you see that your forced vital capacity, your FEV1, and your 25/75 are all reduced proportionately. Okay, and that's what we're seeing here, proportionate reduction in all parameters that we're measuring. And then their ratio is normal, so showing that there's no obstruction there, it's all restriction. And we'll talk a little bit about PFTs when we get to the asthma section, for those of you that aren't real comfortable with them. Okay, and then pectus excavatum, that's the inward bowing of the midsternum, inward cave, that's how I remember it. Can be congenital, familial, or acquired. For most patients, pectus excavatum, pectus carinatum are cosmetic issues. They rarely cause problems. For girls, the excavatum actually might be a good thing, kind of accentuates some cleavage. Carinatum, I don't know that that's ever a good thing, but it's not going to harm the patient other than from a cosmetic standpoint. Now, if it's really bad, we might start to see some restriction, and you can see in this example that his AP diameter is markedly diminished. So if it's really severe, we may show some restriction on pulmonary function testing, but again, most are cosmetic. All right, and then diaphragm anomalies, congenital diaphragmatic hernia. This one occurs in 2 to 4,000 live births, so fairly common. 8% of all major congenital anomalies, again, male predominance. And the mortality here is related to the pulmonary hyperplasia, persistent fetal circulation, and whatever other anomalies are going on. Most common, make sure you circle this one, most common is the Bach-Deleck or posterior lateral, more common on the left side. So your classic vignette for this is going to be an infant who presents with respiratory distress, barrel-chested, scaphoid abdomen. So where that herniated intestine comes in, pulmonary develop is arrested at that point because it simply has nowhere to go. Chest X-ray is going to show you loops of bowel within the chest. For all the world, this could look like a congenital cystic adenomatoid malformation or CCAM, but you can pass an NG tube, see where it goes, and know what you've got. Treatment for this, remember you want to intubate this child. If you sit there and bag, you're just going to fill up their bowel with air, causing further respiratory distress. And then surgical correction as soon as the infant's stable. A couple of less common and very quick anomalies, and eventration. This is where simply a portion of the hemidiaphragm is herniated or elevated. It's almost always congenital, again, usually boys. And this can be an incidental pickup. You just notice on chest X-ray that there's a little hump in the diaphragm, or they can present in respiratory distress, but that's pretty uncommon. Something that I've never seen, an accessory diaphragm. This is really rare, but there is a banding, a fibromuscular banding that actually divides the hemithorax into two parts. Of course, if they're symptomatic, you would need to do something about that. And this is an example of what I'm talking about here. Just, you're coming along, here's your diaphragm, whoop, there's just that little herniation or eventration in the diaphragm. Here we go. 5-year-old, white male comes in. Mom says, he walks funny and he falls all the time. When you ask her what she means, she says, well, he walks on his toes. So you examine him, you notice that he's got a waddling gait. You have him sit down and then stand up, and he sort of uses his legs as a crutch to get up to a standing position. His CPK is elevated. Most likely diagnosis is. That'll be everybody on this one now. This is a gimme. Yeah. Excellent. Okay. So then we all go, why is a pulmonologist talking about this, right? Well, because actually, respiratory system is strongly involved with this. So Duchenne's, most common form of muscular dystrophy. We see it in about 1 in 3,000 males, X-linked recessive. Everybody usually knows all of this. It's a result of a mutation in the dystrophin gene, and these children present between 2 to 6 years of age, exactly like I just put in the vignette. Affected boys usually lose their ability to walk by age 11. You know their classic physical findings. Now, why me? Because as their muscular system weakens, so does their respiratory muscles. And so what we see is aspiration, recurrent pneumonia, recurrent infection, inability to handle secretions. And so we follow patients like this usually a couple of times a year during the early part of their disease. And we follow them with what's called a NIF, or a negative inspiratory force. A normal NIF would be a -60 or better. And as long as they're able to take in that inspiratory force, then they're handling everything just fine. Respiratory failure is often a common cause of death, and so once we see that NIF dropping off and we start seeing -30 or less is when we start having discussions about long-term, what do they want? Do they want trach, BiPAP, vent, etc.? All right, spinal muscle atrophy. So this is the second most common lethal recessive disorder. Make sure you know that the gene is located on 5q. I think most residents coming out now, that's common knowledge. When I was a resident, not so much. The muscle weakness is symmetric. Proximal muscles are typically affected to a greater degree. Remember, with this one, the CPK is going to be normal, as is their sensory and intelligence. 95% of these infants can be diagnosed with gene mutation screening. And there are 4 types. Type 1 being the most severe. This is the infants who present before 6 months of age, often with tongue fasciculations. That's a big one. And that actually might even be, I think, maybe a buzzword for SMA. Feeding difficulties, obviously weakness. And most of these children die very early due to respiratory failure. Type 2, these children initially are doing fine. They're meeting all their milestones, but then they start to lose them. And by age 12 or so, most of these children will die again of respiratory failure, aspiration, infection, pneumonia, something like that. Type 3 and 4 are very similar. Type 3 being a presentation somewhere between 2 and 17 years of age. Type 4 being a presentation somewhere between the 2nd and 3rd decade. But eventually unable to walk or stand without aid. But prognosis obviously better. And then myasthenia gravis. This is super rare in children, but it is the most common primary disorder of neuromuscular transmission in children. The number of postsynaptic receptors is reduced and therefore less sensitive. So there's 3 types. There's neonatal. This occurs when the infant is exposed to a transplacental passage of maternal acetylcholine receptor. And this one will get better. Usually 2 to 6 weeks. Once the antibodies clear, the infant does well. There's a congenital form. This one's autosomal recessive, and they do not have circulating antibodies to acetylcholine receptor. And then there is a juvenile form, which is acquired autoimmune. And this one usually affects girls. 80 to 90%, however, will have these circulating autoantibodies. Diagnosis with myasthenia. So the classic answer for this is edrophonium. But the more I've looked at this, that is becoming a harder and harder drug to get. Or neostigmine would be your other option. And you look for a transient improvement with that. Some of these children will respond to thymectomy with complete remission. And then for those that don't, plasmapheresis sometimes will give you a short-term relief. Okay, so we're going to jump into infection. So upper respiratory illness, this is the bread and butter of pediatrics, the common cold. Most commonly occurring illness I think you're going to see usually in the fall and winter. So who's usually affected? Those in daycare, overcrowding, passive smoke exposure, and of course your school-age kids too. Viral diseases, or viral etiology is usually what we're talking about. So rhino, corona, adeno. And of course we all know the classic presentation. We've all had these. Low-grade fever, runny nose, cough, with viral shedding peaking somewhere between day 2 and 7. So really for these children, all you really need is a good history and a good physical exam. You don't have to do a full lab workup on all these patients. Remember that, of course, a common cold can be complicated by otitis media. They can develop sinusitis. If they've got asthma, it can exacerbate their asthma, and often does. Can progress into pneumonia. Remember that just because they walk in with a green runny nose doesn't mean that it's a sinusitis. Early on, you have that influx of white cells, inflammatory cells trying to fight that virus, and so that may be all that it is. So as far as treatment for the common cold, if you didn't do a thing, you would be right. If you offered antipyretics to maybe make the child feel better, you would be right. Antihistamines are not indicated. They can decrease ciliary motility, they can decrease mucus clearance, and of course, cough suppressants are a big no-no. All right, sinusitis. The most common causes of sinusitis: strep pneumoniae, moraxella, non-typable, Haemophilus. And these children present a little bit differently than just your good old common cold. They usually present with cough. That cough is usually worse during the day and when they lay down flat at night. But the tip-off for you is going to be the duration. So your common cold is going to last 7 to 10 days-ish. This is going to last beyond that. Now, you can do a CT, you can do an X-ray, or you can make a clinical diagnosis. So what do you treat with? Well, you can actually culture this, but I certainly wouldn't do this on every child that rolls in your office. Those that are immunocompromised or not responding, I think, are the ones that we actually want to culture. Remember that it can be complicated by other things such as orbital cellulitis, osteomyelitis, etc. The sinuses are very close to the meninges. But you're going to treat aimed at the most common things. So amoxicillin plus clavulanic acid, macrolides, second, third generation cephalosporins would be really your bread and butter for this. And then, so how long do I treat? Now that's a big question mark that we all still have. The nice thing about question marks, though, is that they're probably not going to ask you that on the board because there's no consensus on it. So treatment duration, 10 to 21 days. I think one thing that they could ask you, though, is a vignette like poorly controlled diabetic presents with a black eschar on the nasal turbinate, and just know that mucormycosis would be what you're looking for in that scenario. So this is an example of a really bad sinusitis where you see complete and total opacification of the maxillary sinuses. This is classically what we're going to see more like in a cystic fibrosis patient, emodal cilia patient, someone who's just got poor clearance. But all of this here should be black, should be air-filled. All right, acute pharyngitis. So we classically see a peak somewhere between 4 and 7 years of age. Very uncommon to see a pharyngitis under 1 year of age. The most common cause, I even highlighted it, most common cause for pharyngitis is viral. For bacterial cause, the most common is group A strep, but this is only about 15% of all pharyngitis. You can sometimes distinguish between the two by presentation. So if you've got like upper respiratory symptoms with rhinorrhea and cough, and then they develop a sore throat, that's probably viral. But of course you don't want to guess. So you can use the rapid detection assays. Those are available everywhere. Important to make sure that you know, because there's complications that go along with strep, as we all know. Rheumatic fever, which is preventable if treated within 9 days, and then of course the post-strep glomerulonephritis, which even if you do treat, can still occur. Treatment is with oral penicillin. IM actually can shorten the disease course. It's a nice selling point for some people. Or if the child is throwing up, obviously can't tolerate. If they're penallergic, your alternatives would be erythromycin or clindamycin. And then the number one question, can they go back to school? Can they go back to school? Yes, they can go back to school within 24 hours of starting treatment. Okay, so other complications of pharyngitis, retropharyngeal abscess. This can occur, the vignette, child running through the hallway with a pencil and falls. So can be a penetrating trauma. But they often present with high fever. They've got hyperextension of the neck. They're drooling because they don't want to swallow, usually tripoding. And we're going to diagnose this with a lateral neck film. It is a medical emergency. If it's fluctuant, then we need to IND this and get the material out and then treat with nafcillin and clindamycin. Peritonsillar abscess. This is always kind of fun to see. I feel bad for them, but it's kind of fun to see. Due to group A strep or can be due to anaerobes. But these children will come in with that classic hot potato voice. So if you've ever put something in your mouth that was a little bit too hot and then tried to speak, that's what we're saying, hot potato voice. They've got horrible throat pain, high fever, and their uvula will deviate to the opposite side from the lesion. So it's going to point away from the lesion. This one also requires IND and treatment with penicillin. Okay. So I threw this one in here, and the next slide just as kind of FYI. What's an indication to refer for tonsillectomy? So they're pretty stringent on who they're actually going to do a tonsillectomy on. Recurrent tonsillitis is defined as 7 episodes of tonsillitis in 1 year, 5 in the past 2, or 3 in each of the last 3 years. It's pretty stringent. Or if they've got marked adenotonsillar hypertrophy, where obviously if one alone is enlarged and you're thinking about a possibility of a tumor, or in a child who's got obstructive sleep apnea. Now adenoids, they'll take those out for pretty much any reason. No, I'm kidding. But if they're persistent mouth breathing, recurrent otitis, adenoid facies, etc., and y'all can see those. But much more lenient with that. Okay, croup. So this is really the other common reason that you're going to see stridor in your practice. And they can have a little bit of stridor, or they can have biphasic, I can't breathe stridor. Barky cough, hoarse voice. So we see a couple of peaks with croup. We see the first peak occurring in the fall. The second peak occurs in usually early winter. And paraflu is the majority of the etiologies. We used to actually differentiate this and say paraflu in the fall, RSV in the winter. They don't say that so much anymore. Paraflu really is the majority, but it can be other viruses. Influenza can also cause this, RSV, measles, etc. Again, more common in males, but a very common incidence, about 3 per 100 children. We see this between 3 months and 3 years, usually that peak in the second year of life. And, it's just so classic. After you've worked in urgent care ER a couple of times, you know what's rolling in your door. You know it. You're diagnosing them while they're still getting height, weight, and vitals, But they start with upper respiratory symptoms, barky cough, and then that stridor appears somewhere around day 2, 3, and then will resolve usually in about 7 days. Symptoms are worse at night, so this is when you have the frantic mom come running into the emergency room. She looks horrible, kid looks great, because she just ran out in the cold night air and the kid got better. So on exam, it just depends on how badly they're obstructed. If they're really severe, then it's biphasic. We can see retractions, or like I said, the kid may be looking great because, they got some cold air. And, diagnosis is clinical. Now, you can do your neck film if you're wanting to be really academic about it, but usually you're going to know. So treatment, if they're at home, then cool mist vaporizer, tell them to go sit in the bathroom, turn the shower on, steam up the bathroom, or take the kid out in the cold air. If they're bad enough when they roll in the door after being out in the cold air and they're still looking bad, then racemic epi is your gold standard. And I've given you the dose there. Remember that you do have to observe them for about 4 hours afterwards to ensure they don't have any rebound. And then steroids can shorten the course and lessen the severity. Okay, so then there's this other entity, spasmodic croup. So this is not what we were just talking about. This is where a kid is going to wake up in the middle of the night. They're going to have barky cough and stridor, but the next day the kid is great. They're running around the house like kids do, getting into things they shouldn't and tearing up things. But then it's going to repeat itself. The next night the kid does the same thing. This is not an infection, and we're not real sure, but we're thinking reflux is probably a big component of what's going on with this. Okay, so if I haven't put everybody to sleep, 3.5-year-old comes in, high fever, drooling, inspiratory stridor. She is actually sitting with her chin extended. She is obviously distressed. The most appropriate thing for you to do would be give her a shot of ceftriaxone and send her to the ENT. Go ahead and take a look and see why she's sitting that way. Look at her posterior oropharynx. Give her a shot of Rocephin and send the family straight away to radiology to get a CT, or refer the child and the parents to the local hospital for examination in the OR. Excellent. So even though it's not common anymore, everybody still knows what to do. I love it. Epiglottitis. So it is a true pediatric emergency, and it is very uncommon since we've started type B vaccine. It's an infection of the epiglottis, supraglottic airways. In the past, Haemophilus was our culprit, but can be caused by Strep pyogenes, Staph aureus. And the incidence at this point, and I just double-checked this yesterday, is about 0.3 to 0.4 per 100,000 in the pediatric population. Very different from what it was 10, 15 years ago. We're going to differentiate this from croup because this is a kid who really looks toxic. It had a rapid onset and the kid looks really bad. High fever, flush, drooling, tongue protruding. If you see that cherry red epiglottis, it's diagnostic. If you see that cherry red epiglottis, you have really done the wrong thing. So do not examine them in the office. If you increase that child's distress, then they can obviously suddenly have a respiratory arrest. So you want to keep them calm. You want to keep them in mom's arms, but very quickly get them somewhere where they can secure that airway. And then treatment is with ceftriaxone or cefotaxime. Bacterial tracheitis, also very toxic appearing child, usually less than 3, high fever, that brassy type cough, but then the child's just going to rapidly deteriorate, requiring intubation. So this is usually Staph aureus. So we're going to treat with nafcillin, and usually requires about 10 to 14 days of therapy. All right, some more bread and butter, bronchiolitis. This is an inflammation of the bronchioles, and again, is usually the result of a viral illness. You know, we typically say RSV. Other viruses can cause this. RSV is just the most common. Typically affects children between birth and 2 years of age, with a peak somewhere in that first year of age, 2 to 8 months. And usually we see this in the winter months, unless you live in Louisiana who doesn't have winter, and then you can see it at any point in the year. There are some risk factors that suggest that this child is going to have a worse course. So family history of asthma, school-age siblings, multiple births, low birth weight, etc. So we're talking about that illness in which there is a couple of days of some low-grade fever, sort of the classic, I consider it more hallmark, clear, profuse rhinorrhea, and I think that would certainly be in the boards if they're trying to pull this out of you in some way or the other. Symptoms peak somewhere around day 4 or 5 with respiratory distress. They often have cough, they have wheeze, they can have poor appetite and poor feeding because they're working so hard to breathe. We can see hyperinflation, where you've got increased AP diameter. You're able to palpate that liver and spleen tip because everything's just hyperexpanded and pushing it down. And then sort of classic for bronchiolitis is those inspiratory crackles that we often hear with that. So you got a kid with clear, profuse runny nose and crackles. This is what you got. So initially, your diagnosis is going to be clinical. Now, again, viral culture would be your gold standard. Culture is always your gold standard. But by the time you wait on that, the kid's either better or is in your ICU. So a more rapid way to make that diagnosis is the ELISA or the DFA. It's faster, and it's really got a good sensitivity and specificity at 90%. So what about chest x-ray? Is that going to help you? Well, it might, and it might not, because about 10% of chest x-rays can be normal with bronchiolitis. If you see the classic sort of diffuse interstitial infiltrates, atelectasis, fantastic. All right, so you're working in your acute care setting. What kid do you send home and what kid do you need to put in the hospital? This is some nice little tips, and some of them are just no-brainers. I mean, if the kid looks toxic, you're not sending them home, right? If they're hypoxic, you're not sending them home, right? But one really nice thing you can do is actually have mom feed the child. If the child can't maintain an oxygen saturation that is normal while feeding, this isn't a kid who needs to go home. And then as far as what are you going to do if you do put them in the hospital? Well, your care is supportive, of course. If they need oxygen, you're going to give that. Steroids are not routinely recommended. Antibiotics, not routinely recommended. And bronchodilators remain controversial. For my little 2 cents on the plug, I think try it, and if it helps, fantastic, and if it doesn't, you certainly didn't hurt anything. If they're really doing poorly, of course, some of these wind up intubated, and I think that's more classically those infants with prematurity that you're going to see. Okay. All right, pneumonia. So in our really young children, this is a hard diagnosis to make. If they are tachypnic and febrile, then it's very likely that this is a pneumonia. But you got to remember that fever is going to raise your respiratory rate by 3 to 4 breaths per minute per degree of elevation. So they may be tachypnic because they're febrile. But if they've got tachypnea and cough, and you heard crackles, and they're febrile, well, now it's probably pneumonia. So who should I x-ray? Well, if they're under 5 and you really haven't found a source, they got a high white count and fever. If your clinical findings aren't clear-cut, if you're thinking that you're hearing some diminished breath sounds, that would be a good pickup in a kid, I'm just going to say. But you're suspecting an effusion, or if you've treated and they're not responding, there's your indications. So what are we going to see if we examine this child? Probably a kid who's screaming and you heard nothing, but you might hear crackles. You could hear bronchial breath sounds. You could hear egophony, bronchophony. You could get dullness to percussion or even tactile fremitus. But then again, you might not. All right, so what is it going to look like? Well, it's going to depend on the host. So if you've got a host who is already compromised because of asthma or some other chronic lung disease of infancy, then what you see may look different than a child who is a perfectly normal host who develops pneumonia. And sadly, bacterial, atypical, viral, they all sort of overlap. And so it's very hard to know when you're seeing that child, is this truly a bacterial pneumonia? Now, you can certainly suspect it if you've got an outrageous white count and a high fever. You're not going to culture all these patients. Now, if you hospitalize with a high fever, I think yes. But if you're in your outpatient setting, I think you're just going to get a whole lot of callbacks. for contaminated cultures. We don't recommend routinely testing for specific pathogens, and we certainly don't recommend SED rates on a regular basis. Okay, so I talked a little bit about buzzwords, and so I threw this question in here because it's got nice buzzwords. So you've got a 3-month-old who has a repetitive staccato cough. That right there should get it for you. It's been going on since 3 weeks of age. The child is tachypnic, has intermittent wheezing. He had nasal congestion and conjunctivitis within the first week of life. There's a family history of asthma, and on exam the child is wheezing, chest x-ray shows hyperinflation. Your most likely diagnosis is chlamydia, pertussis, kid has a web, kid has asthma. Yeah, shame on y'all for doing B, but very good for A. Okay, so chlamydia, you got conjunctivitis in there, come on. All right, so we're going to talk about some causes of bacterial pneumonia. So strep pneumoniae often presents as an abrupt infection. So the child will present with fever, cough, fatigue, maybe throwing up. On examination, you can hear any of the things we talked about, diminished breath sounds, crackles. Remember with strep pneumoniae, sterile effusions are common. And just because a kid has an effusion does not mean everybody needs to run around and panic and start getting chest tubes and tapping. However, if you have a kid who was clinically responding to therapy and suddenly starts to spike fevers and has an effusion, that's a child you want to consider an empyema in and think about thoracentesis and possible chest tube. Strep pyogenes, very similar findings to pneumococcus. Usually the pneumonia is preceded by a rash. Nematocils are very common with strep pyogenes, as are abscesses and empyema. Treatment for this is with penicillin. Anaerobic infection. As a med-peds person, we're going to see this a lot in the adult population, but it's very rare in the pediatric population. Usually we're going to have a vignette of some reason for loss of consciousness, like seizure disorder or syncopal episode maybe. But again, this is very rare in kids. The sputum is very strong smelling, very putrid smelling. Treatment for anaerobes, of course, is clindamycin. And then Staph aureus, much less common, but much more severe when it occurs. Your vignette, I would think, for the boards would be kid recently had influenza, now develops cough, shortness of breath, and on chest x-ray we see infiltrate with nematocils. Treatment for Staph aureus, nafcillin, or if MRSA is a huge concern where you live like it is where I live, then vancomycin would be your choice. And this is a nice example of a nematocil, showing you what we're talking about, what that would look like. Okay. And then viral pneumonia, this is by and away going to be the most common etiology for pneumonia that you're going to see. A nice little tip-off is going to be upper airway symptoms, rhinorrhea, nasal congestion has been going on for several days. Then we get low-grade fever, cough, followed by the tachypnea with wheeze and or crackles. Chest x-ray often shows sort of diffuse type infiltrates. Treatment is supportive, hydration, etc. Okay, so we're going to jump into some fungal infections just real quick. I know Dr. Cross has probably done these ad nauseum, so again, I'm just touching on them. Histo, Mississippi, Ohio River Valley. If you've got that in your story, you need to be thinking about histo immediately. Classically, what we see is hilar adenopathy. Most of these cases are asymptomatic. They're pickups for some other reason. And no specific treatment is usually indicated for this. Coccidiomycosis. So your story here is child recently traveled to the southwest and on return has skin rash and cough. So skin manifestations, what are we talking about? Erythema multiforme, erythema nodosum. We're going to diagnose cocci with complement fixation titers. This is usually self-limiting. It's usually going to resolve on its own. If it doesn't, treatment would be fluconazole, Antho-B. And even if it does resolve, we may be left with some thin-walled cavities that could be a potential setup for other issues. Blasto, central, southeast, mid-Atlantic. Chest x-ray is going to show mass-like infiltrates. Remember with blasto, it's all B's, so broad-based budding yeast is what we're going to see on sputum. Disseminates to bone, and treatment is with ITRA or Antho-B. This is a nice little example showing these sort of mass-like infiltrates that we can see on chest x-ray, these ball-like infiltrates, and on CT what that would look like. And then I guess the last thing I'm going to talk about before we take a break, ABPA. Now I'm not talking about aspergilloma or fungal ball, but the allergic reaction that we have to aspergillus. It's a type 1, type 3 reaction, and usually associated with a really high IgE, often greater than 1,000. The types of patients that you're going to think about ABPA in are those asthma, cystic fibrosis. That would be your two major populations. And the story would go something like child with asthma, previously well controlled, suddenly has clinical worsening, compliant with therapies, chest x-ray shows, fleeting infiltrates, child has an eosinophilia, your buzzword being cough, productive of brown plugs. And in that setting, you need to think about ABPA. Treatment is often with high-dose steroids, plus minus itraconazole if you're having trouble getting those steroids down. And we usually follow IgE as a clinical marker of response. Okay, 19-year-old comes to the local college with fever, cough, chest pain. You're flipping the chart as you're walking in the room. You see that he had been in just a couple of weeks ago with sore throat. Most likely cause is Staph aureus, Klebsiella, Legionella, Chlamydia philia, pneumoniae. Okay. Yeah, so what we were talking about here is your atypicals. So the first one I'm going to talk about is mycoplasma. This is a common cause in children over 5 years of age. They present with fever, headache, sore throat. Remember with mycoplasma, they're going to try and pull in these extra pulmonary manifestations that you're going to see, the bullous myringitis, the neurologic changes. Chest x-ray always looks worse in the patient. And remember, diagnose by IgM antibody, treat with macrolides or doxycycline. So mycoplasma is your M one. Myringitis, IgM, macrolide. And then the chlamydia philia, it's often an epidemic type setting. Children, adolescents, again, looks just like mycoplasma, but usually there's a sore throat in there somewhere 2 to 3 weeks prior to the onset. Treatment is the same, macrolide or doxycycline. All right, so a 10-year-old African-American female comes to your office for a routine checkup. She has a past history of asthma. She's currently being treated with albuterol metered-dose inhaler on an as-needed basis. And she tells you in her visit that she uses it at least once a day for wheezing. So you inquire about nocturnal symptoms, and she says she awakens from sleep about 3 to 4 times a week, either due to cough and or wheeze, and has to use her rescue inhaler. She's been hospitalized about 1 to 2 times every year for the last several years, and she visits the emergency room about 6 times a year with exacerbations. 2 of her hospitalizations were ICU admissions at age 6 and 8. And she's often been prescribed inhaled steroids. She'll usually use them for about a month around the time of hospital discharge, says she notices no difference, and she stops them. But she comes back in for oral steroid burst either through the emergency room or clinic office about every 6 to 8 weeks, and she'll take a burst for about 3 to 5 days. On exam today, she's completely normal, and you hit up your colleague for some spirometry, and here's what you get: a forced vital capacity of 88%, FEV1 of 59%, and an FEF 25/75 or small airways of 48%. So based on the guidelines, this is a patient you can classify because she's on no long-term controller therapy. How would you classify this patient? Mild intermittent, mild persistent, moderate persistent, or severe persistent? Very good. So this is a severe persistent. Okay, so let's talk about asthma. Asthma is a chronic inflammatory disorder. I think that's the most important statement that I'm going to make for the rest of the talk on asthma. It is an inflammatory disorder, and that's what we must control. That inflammation is what causes the signs and symptoms that we see: the airway hyperresponsiveness, the wheezing, the cough. And remember that asthma is a disease that is chronic. People don't outgrow asthma. It is a chronic disease. Your diagnosis is made usually just by a good history and physical exam, and you're going to get those signs and symptoms of shortness of breath, wheeze, cough. You can often elicit the nocturnal awakenings because of shortness of breath, cough, wheeze, and you can often pinpoint specific triggers that are setting off these exacerbations, such as exercise, recurrent viruses, that child that's in daycare who gets recurrent upper respiratory, allergen exposures, etc. And the key point in your history is response to asthma-specific therapy. So if you have somebody who comes in wheezing that has been given albuterol or any bronchodilator and says, well, it didn't help at all, you really need to rethink, is this asthma? On exam, you can see hyperexpansion of the thorax. You may see, if you're an ER physician, accessory muscles and wheezing, but they may be clinically normal, as this young lady was when they walk in. So I told you I'd mention a little bit about spirometry. So this is what I have to say about it. Forced vital capacity. I've shown that twice now. That's the volume of gas that can be expired as forcefully and rapidly as possible after you take a really deep breath. So that's why you hear the respiratory therapists sounding like labor coaches. Push! Right? Take a deep breath. Push! Okay, that's your forced vital capacity maneuver. The FEV1 is how much volume the patient is able to blow out in the first second. That's what the 1 stands for. And then your FEF are your mid-flows, and those coincide with small airway disease. So with spirometry, we measure all of those values. Spirometry is a measure of volume versus time. This can easily be obtained in a specialist office, not so much in a primary care setting, but usually takes us about 10 to 15 minutes. And most children age 6 and up can perform spirometry. I'm not going to say I don't have an 18-year-old who comes through and no matter what we do, they don't get it. And I'm not saying that there couldn't be a 5-year-old who's exceptionally bright and who could do it. But most children 6 and up. And so with asthma, your spirometry may be completely normal. With exacerbation or with long-standing inflammation that has not been dealt with, what we see are obstructive changes. So a decrease in your FEV1, a decrease in those FEF values, and your FVC is normal or only mildly reduced in comparison to the FEV1, which is why your ratio will be lower. Okay, so what are we doing when we see these patients in asthma clinic? Well, we're trying to prevent their symptoms, of course. I would like all of my patients to have normal lung function. For some, that's simply not possible. We'd like them to have normal activity levels, and I tell parents, I want your child to do what every other child their age is doing. I don't like the scenario of the child who stays in at recess and sits there in the classroom staring out the window at all their friends who's outside playing. That's horrible. And so that's one of my goals, is to get them out there with them. We want to prevent those ER, prevent the hospital, and we want to do all this with the minimal amount of side effects that we can. So for your really young, how are you going to diagnose those kids? Well, sometimes it's kind of tough. I mean, what is the difference between a kid with a cold who's got little tiny airways that get mucus plugged and they wheeze versus asthma? And so sometimes just a trial of bronchodilators might answer that question. Daily anti-inflammatory therapy, and I'm going to change the slide next year because I no longer see referrals coming in with cromolyn. I don't know too many pediatricians who do, and I think more and more pediatricians have become comfortable with the concept of inhaled corticosteroids. Remember that you want the lowest dose that's going to control, though, and so we are constantly trying to step down to get the lowest amount that's going to control their symptoms. For your older kids, I think there's a couple of points here. Remember, just because it's a 16-year-old, that's not an adult, and so when you are comparing what their normal peak flow in the ER should be or what their normal values on spirometry should be, they really need to be pediatric norms. The other thing about adolescents is you've got to get them involved. Unless they are tied into their therapy, adolescents are the world's worst at taking medication. So you've got to get them involved in that action plan. And if they don't like the taste of one inhaled steroid, try another, because I promise you, no matter what you say, if they don't like it, they're not going to do it. So get them involved with it and give them an action plan. Give them that autonomy that all adolescents want. If this happens, then we do X, Y, Z. Peak flows. Peak flows, I think, are fantastic if you're sitting in the ER and you want to know how bad an exacerbation is. I think they're wonderful for short term. If you have made a change in medication, are we controlling? But I think they're most helpful in the setting of those patients who simply have no clue. They don't know what triggers them. They don't know when they're triggered. And suddenly they're so bad that they're rolling up into your ICU. That's where a peak flow, I think, is the most beneficial, because you can then give them a plan based on something more objective than just, how do I feel today? Some other issues we see with asthma, of course, sinusitis. There is a high incidence of abnormal sinus films with asthma. When you think about that, that's going to make perfect sense, because what did I say is the most important part about asthma? Inflammation. You get airway inflammation, and the airway is not just lower, it's one airway. So if we're inflaming and increasing edema in the lower airways, odds are that's happening in the upper airway as well, right? So there you go. You get, it doesn't look like the one that I showed you where it's a complete opacification. It's a thickening of that mucosal in the sinuses. So reflux, we see lots and lots of referrals for little babies that wheeze. And, you know, it's really nice when you walk in the room and the baby just refluxes all over mom, because it makes your diagnosis a whole lot easier. It's not always that straightforward, but certainly reflux can make a child wheeze. In your older children, reflux can make asthma worse. And even though people say, well, nobody uses theophylline anymore. Oh, yeah, they do. Yeah, they do. In fact, I just saw one this week that was wheezing, and the pediatrician had started theophylline, and suddenly the kid is spitting up right and left, and he's no better controlled, because theophylline lowers the lower esophageal sphincter pressure, which makes reflux worse. So it's a really important point to remember. And then sometimes you get those really good asthmatics that just with exercise they have issues, and in those patients we often recommend pre-treatment 15 to 30 minutes before exercise. Now that works great for a 10-year-old who's in the running club. That doesn't work so great for a 2-year-old, because when do they exercise? when they wake up till you go back to bed. So that's not going to work for that age group. But for your older ones, that works wonderful. And then, like I said earlier, if they're not responding to asthma-specific therapy, you need to think about, is this really asthma? Could it be something else? Could it be CF? I know there's routine newborn screening everywhere, and I hope nobody gets really comfortable with that because it is a screen and screens miss things. So CF can still pop up even with a newborn screen that was normal. Think about vocal cord dysfunction, sleep apnea, and then look at their environment. You know, maybe they're getting all the right stuff, but they're sitting in the wrong place. They're sitting at Aunt Paula's every day after school, and Aunt Paula smokes. Or maybe they smoke. Or they're simply not taking it. And that's much more common in the adolescent population. Okay, so we talked about classification with the vignette. So how are we going to classify somebody? I love our new guidelines. I think they finally got it right. So impairment, that's those signs and symptoms that they have going throughout the day. Nocturnal symptoms. Can they exercise? How often do they need their albuterol? And then they threw in this new risk evaluation. So how often are they coming to the ER hospital needing systemic steroids? And you can do classification on anyone who's not on controller therapy. So if they're just on PRM bronchodilator, that's the patient that you can classify. And I'm not going to sit here and read each slide to you. Y'all have got them in your handout. But just remember that it steps up with each one. And that intermittent, you're going to have exacerbations less than or no more than once a year, normal lung function. As we get into persistent, then we have an increase in exacerbations, increase in symptoms, so that by the time we hit moderate persistent, we're starting to see some drop-off in lung function. We're starting to see some increased daily use. And then severe persistent, they're extremely limited. Okay, so we talked about infants. How do we diagnose? There is a little bit more help out there, and I think this is pretty nice. So if you have a child, regardless of age, who's had 3 episodes of wheezing, lasting more than a day, affecting sleep, and have risk factors, I think you can feel fairly confident as a pediatrician to say this is asthma. So what are risk factors? Parental history, allergic rhinitis, atopic dermatitis, peripheral eosinophilia, or wheezing that is not specific to a cold. Now, often young children's trigger is viral respiratory illnesses, so that one's a little tough. But if you can document wheezing aside from a cold, that's a really nice documentation. Okay, so we talked about the new guidelines. I think they finally got it right this time. So initial visit you can classify, but the focus of the new guidelines was on control rather than on symptoms. So our goals being to decrease the symptoms, and so we now can reclassify, if you want, as well-controlled, not well-controlled, or poorly controlled once we've initiated that therapy. And the guidelines are very knee-jerk and help you to step up or step down based on that level of control. So this is what we're talking about. So your initial one, how do we classify them? They come in on bronchodilators only, and you fall into, let's just say we fall into moderate persistent. You know, we've met this criteria. Remember, you only have to meet the worst in a group. So if everything else says mild persistent, with the exception of more than once a week but not nightly, I have nocturnal awakening, that's still a moderate persistent. Okay, so you fell in moderate persistent. What do? Step 3, medium dose inhaled corticosteroids. So you do that, and you bring them back, and you go through your same laundry list of questioning. Are you waking up at night? Are you having trouble with exercise? Blah, 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 blah. And what you find out is, no, they're doing fantastic. This is where we are. We're not exacerbating. What are we going to do? So your options at that point, maintain your current step, or consider stepping down if they've been controlled for at least 3 months. I mean, I think these guidelines are very, very helpful, and if you post them somewhere, you've got a very nice reference to say, this is what I need to do to control, and When they come back for follow-up, oh, look, they are controlled. Here's what I can do. Know these guidelines. Okay, so if we go back to the previous question, 10-year-old classified as severe persistent, what is going to be the best treatment for this patient? Are we going to continue her with bronchodilators as needed? Are we going to go with a leukotriene modifier as monotherapy? Are we going to go with low-dose inhaled steroids? Or are we going to go with low-dose inhaled steroids plus a long-acting bronchodilator? That's all your choices. I'm not giving you any others. What are we going to do? Very good. Okay, so let's talk about therapy real quick. So therapy for asthma can be broken up into quick relief and then long-term control. So your quick relief includes not only your beta agonist, but also your systemic steroids, because that's the way they should be viewed. They shouldn't be your controller therapy, but many families use them as such. Your long-term controller medications are your inhaled steroids, your mast cell stabilizers, very rarely used now, long-acting beta agonists, your methylxanthines like theophylline, and then your leukotriene modifiers. So steroids, most effective agent there is. You can control anybody with oral steroids. However, you are going to have lots of adverse effects, and I would say know them. I've taken 4 boards to certify. I can tell you it's been on every single one of them. Know the adverse effects of steroids. Inhaled steroids, at a moderate dose, however, as long as you do them correctly, use your spacer device, rinse your mouth adequately, really are not associated with these risks. The other ones that we talked about, cromolyn sodium, mast cell stabilizer, given by MDI nebulization, minimal side effects, not the best therapy on the market, though. There are many, many that are better. Long-acting beta agonist, I have 2 words of caution for that one. Don't use it as monotherapy, and don't use it as monotherapy. It does give you 12-hour bronchodilation, and I will say that despite its controversy, it has saved so many children from requiring that daily steroid therapy. It is a great drug when used in the right population in combination with an inhaled corticosteroid and never as a rescue. Leukotriene modifiers either inhibit leukotriene production or receptor binding. They are fantastic for exercise-induced asthma. They are fantastic for asthma that has an allergic rhinitis component. Sometimes we will see behavioral changes with leukotriene modifiers, but overall it's a fairly safe drug. And then theophylline, like I said, rarely used nowadays, but people still do. It does require serum monitoring. It has lots of toxicity if you get too high. Can cause GI symptoms, behavioral changes. And often the one that the boards would like to pick out is that drug-drug interaction with theophylline. So remember that your fluoroquinolones, cimetidine, there's another one. Say it. All I hear is macrolides. Thank you. Yes, macrolides. Wow. Okay. And then identifying your patients who are going to be at risk. So remember, I use this when I'm talking to parents to try and improve parental compliance, if you know what I'm talking about. So if you talk to the parents in terms of your child is a child who can be at risk for sudden death from asthma if they have had 2 or more hospitalizations in the past year, 3 or more emergency room visits in the past year, if they've been hospitalized in the past month, if they're using more than 2 canisters of inhaled beta agonist, that usually gets that deer in the headlights look from the parents. Like they'll kind of get, oh my gosh, this is my kid. And often you can improve that parental compliance by talking about this. And those are listed there for you. Okay, so let's look at this one. We have a 3-year-old. She comes in for a chronic cough for 2 months. She's been on steroids, she's been on bronchodilators, she's been on antibiotics without resolution of her symptoms. She's got a history of some seasonal rhinorrhea and nasal congestion, but otherwise she's been a pretty healthy little girl. On physical exam, height and weight at the 25th percentile. She's got some erythematous nasal mucosa, no polyps, no nasal discharge. She has on auscultation a localized area of wheezing in the right lower lobe. So in this patient, you are thinking asthma, allergic rhinitis, foreign body, or does this child have an immunologic disorder? Very good. Excellent. So when we talk about a localized area, this should be the first thing, and particularly in that age group. Foreign body aspiration can be anything that goes in the mouth, and kids are fantastic for it. So it might be normal stuff, and it might be coins or balloons or a piece of Mardi Gras beads or, you name it. It might, if it fits, it can go there. Most of them lodge in the right or left main stem, and so often you're going to see a kid who's going to present with choking and coughing and shortness of breath. However, they may not. That may have happened and mom was in the kitchen frying chicken, right? And never saw it, never knew about it, and so then the kid starts with the chronic cough. Again, up to a quarter of your chest x-rays may be normal just on plain film, and so how are you going to diagnose this? So if you have a kid who's cooperative, you can do inspiratory and expiratory films. And with expiration, you're going to see that area of hyperinflation because of the ball valve effect of the foreign body. So hyperinflation, maybe a mediastinal shift. But you might have the kid who's screaming from the minute they roll in the door, and that's what they always do. So they're probably not going to do, hold your breath real good and let's take a picture. So for those, you can do lateral decubitus. So the side down should compress. Gravity does take over, as I've noticed. However, with foreign body, you're going to see hyperinflation there. Fluoroscopy will do the same thing for you, just as they spontaneously breathe. You can see that. All right, remember, don't stick your finger in there. I don't think anybody's going to be silly enough to do that, but don't do it. If they're under a year, you do the back blows, and then older kids, Heimlich maneuver. And then just keep in mind that with a foreign body, a rigid bronchoscopy is what's necessary. Flexible bronchoscopies for pediatrics are very small, and so you can't really fit a device down there to retrieve. So you really need a rigid scope that you can actually not only see it, but get it back out. And antibiotics are not usually required unless it's sat there for 2-3 months and you've got purulence behind it. Okay, bronchiolitis obliterans. We're seeing this more commonly in post-transplant patients, but can be caused by a multitude of disorders, and one of the more common is adenovirus. Native Americans have about a 2/3 risk of development of bronchiolitis obliterans following adenovirus. So what is it? It's where the bronchi and bronchioles become plugged with fibrous tissue, and this results in hypoxia, hypercarbia. Lung biopsy is what confirms it. However, you can certainly suggest it. Now, this is a young man who has bronchiolitis obliterans. And what you see is this variable perfusion on CAT scan. So one area where you've got just, oh my gosh, a whole bunch, and then the next cut down, you've got a paucity of vessels. And that certainly would suggest to you that this is what you're dealing with. And then, like I said, in the post-transplant patients, this is one of our #1 reasons for death post-transplant. How about bronchiolitis obliterans with organizing pneumonia, now called COP? I love that. So what is it? This one is a thickened alveolar septum. So we have this influx of inflammatory cells. We've got an increase in type 2 cell hyperplasia. Can be caused by a multitude of things, usually collagen vascular disease, but can be toxic inhalants, can be a result of a really bad pneumonia, can be idiopathic. And they'll present with these recurrent episodes of bronchitis with or without infiltrates that respond to antibiotics, but as soon as you're done with the antibiotics, it comes right back. And steroids are really the treatment for this. This was a young man who has idiopathic version. Chest x-ray during the initial visit showed these bilateral lower lobe infiltrates. And CT, again, showing diffuse disease in the lower lobes. And what's a board review class without some path, right? Boo. But, okay, so I'm not a pathologist. Here's what I see. I see lots of dark dots, and I'm sure y'all see dark dots too, and that's that influx of inflammatory cells. That's the important point that I'm going to get from that. Okay, so what about some other causes of wheezing? Bronchiectasis can certainly cause wheezing. Bronchiectasis is a dilation of the bronchi. These patients present with chronic, usually a productive cough. They can have wheezing. They can have clubbing. They have a large total lung capacity, a large residual capacity, which is what actually makes up that large TLC, but then a small vital capacity. We're going to see bronchiectasis in cystic fibrosis. We can see it with chronic aspiration, long-standing aspiration that hasn't been picked up. We see it in immune deficiencies, and we also see it in ABPA in our asthmatic population. Once it dilates, like I said, it's usually irreversible. So then our therapy is aimed at how do we keep the secretions from building up in the airway. So bronchodilators, some form of airway clearance, be it postural drainage or the more common airway clearance devices like the vest, what have you. How about a modal cilia syndrome? So the best known, everybody says cartageners, and they use immodal cilia or dismodal cilia and cartageners synonymously, but cartageners is really just a type of. With cartageners, they have situs inversus, sinusitis, bronchiectasis, reduced male fertility. Immodal cilia has all of that without the situs, so you don't have to have situs to have immodal cilia. They often have an absence of the dining arms, one, both, or even the spokes can be abnormal in there. The treatment is the same as for bronchiectasis, and they look for all the world like a CF patient without the stomach manifestations. Their prognosis is much better, though. Okay, apnea. So let's start with apnea prematurity. Common problem in our preterm. Rarely do we see this in our term infants. If we do, it's always pathologic. Remember that to have a normal control of breathing, you've got to have a good central respiratory drive, you've got to maintain that airway patency, and you've got to have adequate functioning of your respiratory muscles. And if you don't have, or if there is an issue in one of those three, that is when we can see apnea occur. So apnea, we define it as the absence of airflow greater than 20 seconds or less than 20 seconds, but associated with bradycardia or cyanosis. And it can be obstructive, it can be central, or it can be mixed. For prematurity, we typically will see this in the first or second day of life. And if they're born after 28 weeks gestation, they typically resolve before 37 weeks. However, if they're born and they are not apneic and they go along for about a week and they're breathing just fine and suddenly we start having periods of apnea, you need to think about something other than just apnea prematurity. You need to look for another cause. So what could precipitate it? So there's a laundry list, and I've just picked out the big ones for you. Hypoxia, infection, temperature instability, intracranial hemorrhage. So who do you treat with apnea? Well, if they're turning blue or their heart rate's dropping, please treat them. But if it's occurring frequently or it's prolonged when it happens, of course, we're going to treat those too. So how do we treat them? Supplemental oxygen. nasal CPAP if needed. Methylxanthines, sometimes caffeine can be helpful, I'm sorry. Remember that infants can have periodic breathing where they have 3 or more pauses. Those pauses last more than 3 seconds with less than 20 seconds of normal respiration in between. This is normal preterm breathing. This is not apnea. Also remember, apnea is not a risk factor for SIDS. Okay, so what about obstructive sleep apnea? So now I'm not talking about those newborns, I'm talking about those older kids. In the pediatric population, we have an incidence of about 1 to 3%. I think that's probably lower than what it probably really is. Peak prevalence, 2 to 6 years of age. Who's at risk? Well, we all think about the Downs children, but those with craniofacial anomalies, achondroplasia, or even neuromuscular disorders, you really need to think about sleep apnea in those populations. Oftentimes, as pediatricians, we forget about sleep apnea. That's that disorder that happens in adults who are overweight, right? Well, not always, and certainly a child who's got restless sleep, we think, well, okay, kids sleep restlessly. I mean, anybody who has kids and has slept with them probably walked away with a black eye at some point. I know I have. Is that sleep apnea? Not always, but you do need to dig a little bit more. So often, if we're having this, it's occurring in the wee hours of the morning when we're sleeping anyway. Even if kids snore, it's not like your husband who's rattling the pictures on your wall. And so, you know, oftentimes we miss this. But as pediatricians, we really need to look harder because that skinny little hyperactive kid who's climbing the walls in your treatment room could be your sleep apnea patient. Some things that might tip us off: allergic disease, mouth breathing, if they've got, as we said, craniofacial deformities or anomalies. When we're doing our oral exam, look at their tongue size, look at their tonsil size. If those tonsils are touching, ask those questions. Long-standing obstruction, we can actually see a pectus deformity develop. In late stage, they can even have signs of cor pulmonale. So you've really missed the boat at that point. Polysomnography or sleep study is the gold standard for making that diagnosis. Now, some people can do nap studies. Their hospital or facilities allow them to do that, and those are great if you document sleep apnea. However, the negative predictive value is horrible. So if you don't catch it in the nap, that doesn't mean they don't have it. They still may need a full sleep study. For kids, the first treatment line is going to be adenotonsillectomy. That's your first step always. When you panic is when you've already done that and their sleep study still shows sleep apnea. What do we do now? So your options are epiglottoplasty, tongue wedge resection for like your Beckwith-Wiedemann patients, trach placement, and some children can actually learn to tolerate CPAP, but it does take some working with. Okay, the following has made the greatest impact on the reduction of SIDS death. It's another gimme. Come on, guys. Efforts to reduce maternal smoking. Back to sleep campaign. Home monitors. Avoidance of soft materials in the infant sleeping environment. Very good. Notice the only 0 on there. So sad. Okay, very good. So what is SIDS? The sudden death of an infant under a year of age, which remains unexplained after you've looked at the scene, you've done a complete autopsy, you've done a thorough case investigation, and you still have no answer. That's a SIDS death. Third leading cause of death in infants, age 1 to 6 months. Estimates are about 0.5 to 0.6 per 1,000 infants. The vast majority occur within the first 6 months of age, with that peak being between 2 to 4 months of age. And then highest rate being in Native American, followed by African American, Caucasian, then Asian. So some specific infant risk factors for SIDS. What is it about that particular child that would make them be at higher risk? So if they're born less than 37 weeks or less than 2,500 grams, if their APGAR score is low at 5 minutes, if they have BPD, if they've had a previous acute life-threatening event, or a sibling with SIDS. Those are some examples of things specific to that infant. Risk factors that mom puts the child at risk for SIDS. Anemia, smoking, alcohol, drug abuse, and young maternal age are all maternal risk factors. And then just additional risk factors, obviously prone sleeping, soft bedding, overheating, race, ethnicity, and socioeconomic status can all be independent variables. All right, drowning. I don't see too much of this. I guess y'all do. Second major cause of unintentional death in the United States, with 2 age peaks, the very young and the crazy teenage boy who thinks he's invincible. So with a drowning or near death, we get an aspiration of fluid into the lungs that causes a loss of pulmonary surfactant that can lead to pulmonary edema and ARDS. It's important if you do work in an acute care setting that you remember that that chest x-ray can be completely normal when they first roll in there, but that doesn't mean it will be 24 hours later. With CPR, make sure that you are performing this with the knowledge that there could be a cervical spine injury, and if you live somewhere not where I live, where it's cool, then resuscitation should be continued until the temperature is 32 to 35 degrees Celsius. All right, so risk factors for poor prognosis, if they were submerged more than 10 minutes, resuscitation takes more than 25, they're young, the water temperature was warm. What's important from here is that there are no good early predictors of poor outcome. So you really don't know if you're able to resuscitate them. What's a predictor that's going to tell me this child's going to do poorly or this child's going to do well? It's really not there. Okay, BPD. BPD definition has changed more times than I can imagine. I think they're competing with the ID guys to see how they can change stuff every year. But the best definition, I think, is this: oxygen dependency, abnormal chest x-ray, or persistent signs of respiratory distress after 36 weeks post-conceptual age. I think that's the best one. So with BPD, what we see is that there is an increase in airway resistance. There is a decrease in lung compliance. So we've got stiff lungs, and that's what causes the wheeze, the shortness of breath, the increased work of breathing, all the things that we see with BPD. So our best therapy is prevention. So if we can delay birth or use prenatal steroids and prevent this from occurring, that's our best bet. This is a young child who obviously didn't have that go. But the chest x-ray is very classic in that it shows the typical alveolar and interstitial pattern that we see with BPD. There are other risk factors other than just being born early that contribute to BPD. And I think a lot of people now are recognizing, ICU-A, I think this comes with quality improvement and best care practices. ICU-A has a 12% incidence, ICU-B has a 30% incidence. Why is that? If you look at child per child, everything else looks the same. So there's something happening outside that contributes to it. Infection, how early do we close a PDA? What micronutrient deficiencies do we address? What infection control policies are in place? There are other factors other than just prematurity. Our treatment, once they are discharged from the ICU, low-flow oxygen is our mainstay. We want to maintain normal oxygen saturations by normal 92 to 96%. And if we're doing it all right, that infant should gain about 20 to 40 grams per day. That's a nice little number to stick in your head to know how you're doing. Furosemide can be helpful. Bronchodilators can be helpful. Steroids really are not going to shorten BPD, so not helpful. RSV prevention, however, is, and is a big deal. So you want to get that going for any infant who meets the qualifications, typically starting around November for most of the United States. And you want to continue it until the end of RSV season or until they've reached their maximal eligible doses. It doesn't interfere with any other vaccine administration, and it's important to remember that just because you've had RSV, that's not protective. You can still get it again. So those new recommendations that I still find, no matter how many times I read it, a little bit confusing. Minimize the number of doses that infants now receive, but decrease the number of risk factors that they needed to get therapy. So now we only have 2. Your risk factors are either you attend some sort of child care or you have a sibling under the age of 5, and that's it. That was the easy part. Now here's the other part. So they can have up to 5 doses if they fall on the left-hand side of the chart. They have chronic lung disease and they're less than 24 months, congenital heart disease, if they're born less than 32 weeks, or if they have certain neuromuscular disease congenital anomalies. They are eligible for at most 3 doses if they were born between 32 weeks and less than 35 weeks, and they have at least 1 risk factor, and they're born 3 months before or during RSV season. Y'all got that? Fantastic. That's how I feel about it too. But I've shown it to you. Okay. Another question. 8-year-old comes in, has cough. That cough is a productive cough. She actually coughs up yellow sputum. She has some low-grade fever and headaches. She says her cough is worse over the past 2 weeks, and it's frequently associated with post-tussive emesis. She's actually, as you pick out the history, though, been coughing for about 4 years. And her cough is worse in the morning. It's worse if she gets a cold. Both parents do smoke, only outdoors. Her weight is on the lower end of the chart, 10 to the 25th percentile, height's at the 10th percentile. When you listen to her, she's got some wheezes, and she actually has some crackles in both upper lobes. She coughed, and she actually gagged with her cough. You really don't find anything else. What are you going to order next to make your diagnosis? You can do an immune workup, pH probe, sweat test, or a methacholine challenge. Very good. All right, so we're going to change into cystic fibrosis. All right, so cystic fibrosis is a chronic multi-system disease. It is life-shortening, although we're working on that. Our median age now is almost 38 years, so we're doing much better. Results from a defective ion transport across the epithelial surfaces, and it does affect multiple systems, respiratory, gastrointestinal, reproductive, and even endocrine to some degree. The predominant morbidity is, of course, the lung disease. We can see pancreatic malabsorption in about 85% of our population. We can see diabetes, liver manifestations. A lot of our patients have chronic sinusitis. They do have elevated sweat electrolytes. And our males, 99% of the males will be sterile. Not 100, but 99% of our males will be sterile. And our females have a reduced ability to become pregnant. It is the most common recessive genetic disorder in the Caucasian population, and we have about 30,000 individuals in the United States currently with cystic fibrosis. So I've updated this for y'all, and I think the really cool thing to see here, so if we look at all patients in the registry, there's still a large chunk of our patients who were diagnosed with respiratory or GI manifestations of disease. But I think the really neat thing is if you look at the bottom of the slide. So of all patients in the registry, about 13% were diagnosed by newborn screening. But of those that were newly diagnosed in 2010, over half of those were diagnosed by newborn screening, which means they were asymptomatic individuals at the time of diagnosis. I think that is so cool. So our respiratory symptoms, like I said, that's usually our cause of death in these patients. And what we see is mucus obstruction, which leads to infection and subsequently influx of inflammatory cells with airway destruction and bronchiectasis. Early on, what we're going to see is Haemophilus and staph, but as time progresses, Pseudomonas becomes our major culprit. And of course, we can have airway hyperresponsiveness in these patients, an asthma-like picture, if you will. Pulmonary hypertension, ABPA, we talked about earlier. Initially on chest x-ray, we see hyperinflation because of the mucus with subsequent air trapping behind it, but later on, we start to see that fibrosis and bronchiectasis, initially in the upper lobes, but ultimately involving all the lung fields. This is an example of a young lady before transplant, and you can see just diffuse involvement of pretty much all lobes. And again, you can see almost like you could take your tweezers and pick out little dots in there from the mucus plugging. And then this is a very nice example of bronchiectasis with dilation of those airways all the way out to the periphery. So what about this? An 18-year-old comes in with a sudden onset of chest pain and shortness of breath after coughing. Most likely reason for the chest pain is she's got pneumonia, she's got a pulmonary hemorrhage, she's got a mucus plug, she's got a pneumothorax. Very nice. And actually, those of you who did put C, it may have been that started it, but ultimately her chest pain was from the pneumothorax. So this is a nice example showing your pleural line here. This young lady actually drove herself to clinic and said, "My lung is flopping in my chest." It's tougher than I am. All right, so other than our newborn screen, who do we think about might have CF? Well, if they've got persistent wheeze, persistent cough, recurrent pneumonia, persistent radiographic changes, think about it. Cough is very common in children, but you need to keep that index of suspicion high. So if you've got persistent and or recurrent symptoms, you do need to put it in your differential. Their gastrointestinal symptoms, the pancreatic insufficiency is that loose, foul-smelling, greasy stool, about 80–85% of our patients. But remember, 15% will be pancreatic sufficient. Big appetite, but yet failure to thrive. Back in the day before newborn screening, we would have the mom come in saying the child was taking 6 8-ounce bottles at 1 month of age and was losing weight, you know. So really big appetite. Meconium ileus, that incidence really is not changing. If they're going to have ileus, they're going to have ileus regardless of newborn screening. And that's, I don't know that we're going to fix that one. And many of these children were initially labeled as formula intolerance because a vast majority do have reflux. And so lots of things were fiddled with before the diagnosis was thought of. They can present uncommonly. We've had referrals from ENT strictly for nasal polyposis. We've had referrals from even an ophthalmologist who was very astute and picked up on a vitamin A deficiency with xerostomia. But they can have skin rashes due to fatty acid vitamin deficiency, even hypochloremic metabolic acidosis, which is the classic sort of finding, but not often in practice. So once we're thinking about them, how do we diagnose them? So they've got to have one of the characteristics we just talked about, one of those respiratory GI manifestations, or a sibling who has CF, plus either an elevation in their sweat chloride, the identification of 2 disease-causing CF mutations. This is getting more and more complicated. Or the demonstration of those characteristic abnormalities of ion transport using something called nasal potential difference, and really only about 10 centers in the country perform the nasal potential difference test. For the sweat testing, it must be the quantitative pilocarpine iontophoresis. Lots of places do a screen, and screens are nice unless you're looking at the newborn screen, and don't ever screen a screen. That is redundant and silly. The screens have a very high false positive. They can give false negative, but they have a very high false positive rate. With the acceptable test, concentrations of 60 millimoles or greater is consistent, and we do repeat that on separate dates for confirmation. I'm putting this slide in here so that you can say you've seen it. Things that can cause a false positive, nephrogenic DI, hyperthyroid, a lot of these mucopolysaccharidoses, those sort of things can do it. There are very few things that cause a false negative, though. All right. So the ultimate problem is this one protein, this transmembrane conductance regulator that's supposed to move sodium and chloride across that epithelial surface. And 25 years ago, they found it, they isolated it, they knew what it was, we were going to have a cure. And since then, we're now up to something like 1,700 mutations have been identified. Now, not all of those are disease-causing, which is why I think I need to do another fellowship in genetics, but it is getting very complicated. Our current studies, if we're looking at just mutations, we screen for 97, most common being delta F508. And within that 97, we're going to pick up about 80–85% of our patients. So we used to say confirming with DNA was nice. Maybe you could give the family some genetic counseling. You could predict pancreatic status. But actually, the current therapies are moving toward targeting specific defects. And so actually knowing what mutation a patient has is becoming more and more important for us. And then newborn screening, this has been the greatest thing since sliced bread, I think. So we do it at the same time as we do the heel prick for the PKU and the hypothyroid. Unless and less we get that phone call, this patient has CF based on their PKU test, people are actually starting to understand what's happening. So most places do an immunoreactive trypsinogen as a first line. And then it sort of varies state to state from there. Some people repeat that IRT. Some people just run delta F508, looking for just that one mutation. Some people do many mutation panels. So I can't say what your state does, but I can say that your state does something, because now all 50 states do. With the IRT, a normal value would be 140 or less. Every state has its own little cutoff for that one as well. But the point of why this is so important is that the long-term studies have shown us that if we can pick them up before they're symptomatic, before we have respiratory symptoms, before we have failure to thrive, they're going to do better all the way into adulthood. We're going to have better lung function, better nutritional outcomes by picking them up before we've lost ground. And then, of course, we start this comprehensive treatment program from day one. We know that they're going to do better if they're followed in a CF center. And we encourage physical fitness and good nutrition, play soccer, go run, go do something, karate, I don't care, go do something and be physically active. Those patients do the best. So with the respiratory, our goal is to slow the disease progression. We're not going to stop it. We're not going to make it go away. We just try and slow it down. And we do this by using bronchodilators on a routine basis, followed by airway clearance. We use things to decrease the thickness of the sputum, like alpha-dornase, and now the new one is hypertonic saline that we're using, a 7% saline solution. We do a ton of antibiotics, IV antibiotics, oral antibiotics, inhaled antibiotics. And for your boards, just remember ceftriaxone does not cover Pseudomonas. That is not one of the antibiotics we use. And then for the gastrointestinal symptoms, enzyme replacement, they swallow, a couple of pills before they eat their meal, and we can get about 80% of fat absorption doing that. We use things to decrease gastric acid hypersecretion. We supplement their fat-soluble vitamins. And then maybe 15-20% of our patients, no matter what they eat, they're consuming 3,000 plus calories a day and they're still not growing. Those patients require gastrostomy feedings at night to help us optimize that nutrition. All right, alpha-1 antitrypsin. So we're going to switch gears a little bit. The biggest thing I want to say to you guys about alpha-1, it's not me in kids. It's not pulmonary in kids. It rarely, if ever, causes pulmonary symptoms in children. Those we see somewhere in the 4th, 5th decade of life. It can cause, however, GI manifestations in children, and that's very important. Liver fibrosis, cirrhosis, very common in PIZZ. So you need to be looking for that. The alleles responsible are located on a PI locus. The majority of us in this room would be PIMM, that is the normal, with levels of about 200. The PIZZ, which is what we see with alpha-1 antitrypsin, have levels around 10 to 20. Those who have like an MZ or a ZO, heterozygotes of some form, have reduced levels, but usually do fairly well unless they decide they want to start smoking. So you want to think about this in your older population, 30s, 40s, in somebody who's never smoked and develops early onset COPD, and the difference would be that the emphysematous bullae that they develop are not in the upper lobes, but are in the bases. So that's your little hallmark pickup. How about sarcoid? We see that a lot in adults, but also rare in children. On chest x-ray, it can be variable. We can see lymphadenopathy. We can see interstitial lung disease. We may see a combination of both. Everybody thinks ACE level, sarcoid. Yeah, but that's pretty nonspecific, guys. That's not really going to tell you just a whole lot. If it's normal, does that mean they don't have sarcoid? No. If it's elevated, does it mean they have sarcoid? No. So I don't know that that's going to give you a whole lot. You can do a bronchoalveolar lavage, look at helper suppressor ratio of the lymphocytes. That might be helpful, but really your diagnosis is best made by biopsy. And you can biopsy anywhere within the airways in somebody with sarcoid, and you will get that diagnosis of non-caseating granulomas. When you see that, you do need to send for microbiology to make sure that this is not due to some infection, but it's really easy to get with biopsy. If they have erythema nodosum, that portends a good prognosis for the patient. However, the vast majority, 3/4 of the population, will recover really with no specific therapy. If they're really bad, steroids are our mainstay. This is an example just showing like really nice hilar adenopathy in a patient with sarcoid. You can see here on CT. Okay. So how about even more rare, alveolar proteinosis? So this happens because the macrophages are defective and they don't chew up the old surfactant, and so it just builds up within the lungs. So then the patients become hypoxic because they can't move oxygen and CO2 adequately across the membrane because they got all this goop sitting there. So we get this big shunting. You diagnose this one again by biopsy, and the treatment is very cool. It is a whole lung lavage under general anesthesia. So you intubate a single lung, you ventilate the other one, and you lavage out that lung until you get it clear. This is a young lady with an example. And again, this is the picture of, I could take my tweezers and I could pick out individual dots because this is an alveolar type infiltrate. And on biopsy, this is what you would see. So all the pink stuff that's sitting in there, that's the abnormal stuff. That's the buildup of surfactant, like here. And this is what happens in the OR. So you start out with sort of this potato soup looking material that you're lavaging, and you just simply saline in, saline out until you ultimately wind up with this nice clear fluid. Oh, come on, that's cool. That's not ew. Man. All right, so we're on the downhill run, guys. Interstitial lung diseases can be caused by collagen vascular disease. Lupus, the great mimicker, can cause, you name it, pleuritis, effusion, atelectasis, picket, it can happen, even hemoptysis. Lupus affects both lung and pleura more commonly than any other collagen vascular disease. Scleroderma, however, affects the lung alone, even more commonly than lupus. With scleroderma, we get this interstitial fibrosis, this intimal proliferation that ultimately leads to pulmonary hypertension. There's just a little tidbit buzzword down at the bottom. Sjogren's is associated with lymphoid interstitial pneumonitis. The other big one that they might tie with that would be HIV. And that's really the only two things that I think the board would pick on you with that. Sjogren's, HIV, LIP. Okay. So what about hemoptysis? I just mentioned it with lupus. Most common reason for hemoptysis is infection or chronic bronchitis. Can be caused by foreign bodies in kids, can be caused by bronchiectasis. Then we have these others, like vasculitis, AVMs, much more rare causes. So if you're seeing the kid who comes in, mom says they're coughing up blood, first thing you got to do is prove it. Did it really come from the lungs, or was this a GI source? So what did it look like? That would help. And then what other signs and symptoms are associated? So is the kid running fever? Is there a history of drug use? Is there blood in the urine? That's going to move you toward a different pathway. Is there clubbing? Thinking about bronchiectasis. Remember that, like most things, the chest x-ray can be completely normal. In that setting, you may want to consider a bronchoscopy with lavage to see if you can actually document that there is bleeding in the airways. If it's not actively bleeding, you could at least document that there's hemosiderin within the macrophages, which would indicate that there had been bleeding. And if so, you might want to think about an echo, because congenital heart disease can also do that, and consider a lung biopsy. Okay, so the last couple of things I want to talk about, so we're going to be done a little bit early, guys. Idiopathic pulmonary hemosiderosis. The important thing to remember about that is the very first word in its name. It's a diagnosis of exclusion. So you are responsible for documenting that it's not any of the other good reasons for coughing up blood before you can use this diagnosis. It often comes repetitively, but can come as a single event, and you never see it again. But again, the important point being that you've got to document that it's not something else. So what about good pastures? Good pastures is autoimmune. It's going to look like idiopathic pulmonary hemosiderosis, except that you also have renal involvement. You see this deposition of IgG and C3, both on the alveolar and on the glomerular basement membranes. The distinguisher between good pastures and Wegener's is that there is no upper airway signs in good pastures. You treat this one with immunosuppressives and plasmapheresis versus, oh, this is just a nice x-ray of what a pulmonary hemorrhage could look like, what an IPH could look like, what a good pastures could look like, what any etiology for coughing up blood might look like. Okay, So versus your Wegener's, which is actually a vasculitis that affects the respiratory sinuses and pulmonary vasculature, causing nodules. It also affects the kidneys, causing a necrotizing glomerulonephritis. You diagnose this one by biopsy. An ANCA can be very helpful. If your ANCA is positive, it's always going to be C ANCA, not P ANCA. That's what's associated with Wegener's. But keep in mind, it is the upper airway signs and symptoms, along with the hematuria, the renal involvement, and the pulmonary involvement that gives you the Wegener's. This one is treated with cyclophosphamide plus minus steroids. And this is just a nice example of what those nodules might look like. Very nice, big nodules, sometimes cavitary. And we got it, guys.